Thank you, Dr. Rao, and it's my honor to be a speaker in this acclaimed international forum, and I hope at some point of time the publication record will help considering a membership to this August gathering. So for the first 15 minutes or so of today, what I'm going to be talking about is about vision after refractive surgery, and the title of the talk is Why 2 is Better Than 1. The reason why I chose this topic for presentation today is because some years ago when we actively started pursuing refractive surgery at LV Prasad Eye Institute, we were wondering what we could do different from routine refractive surgery. And we realized that most of what has to be done in refractive surgery already seems to be published, at least the easy stuff. And so as we gained more experience in this field, we started to realize that most of the stuff that is published is what can be researched very easily. What isn't published is something that is not obvious to most refractive surgery patients as well as surgeons. So I'll start with a little bit about the evolution of refractive surgery. All of you know how refractive surgery evolved. You all know that Rahul started with RK as the first mainstream procedure in the 1970s, followed by PRK in the late 1980s, then with LASIK, which was popularized by Palikaris from Crete in the 1990s, and then evolved to femtosecond laser surgery, including SMILE in 2004. So if you look at the evolution of refractive surgery over the years, surgery has become safer, it's become more predictable, and the results have become more accurate. It can be broadly classified into 3 subcategories as of now. You have incisional refractive surgery. The only remnant which is widely practiced right now is astigmatic keratotomy, since radial keratotomy is not a mainstream procedure anymore. Then you have ablative laser surgery, which is probably the most popular and the most widely performed kind of refractive surgery. And then you have implant-based surgeries, which imply putting phakic lenses inside the eyes of patients. A 4th type of refractive surgery called non-ablative laser surgery has come into vogue since the last several years, and the prototype of this surgery is SMILE or RELAX as it is popularly known. So since many of you in the audience would have been doing refractive surgery or have been seeing patients after refractive surgery, one of the commonest scenarios that you'll probably be confronted with in the clinic is on the first day post-op when a patient is asked to read the vision chart. Some patients say, "Doc, I can see the chart, but this is not what my vision is. I cannot see very well outside." And then once you finish testing their vision, a lot of patients say, "But doctor, this eye is better than the other eye." Now, the commonest answer that I give such patients is the fact that before surgery, if you had checked your vision between the 2 eyes, they probably would have been different too. And they continue to be different right now. The reason why refractive surgery is done for you or you are a candidate is because we aim to try and give you good binocular unaided vision acuity. And because of that, a number of refractive surgeons across the world tend to stress on binocular visual acuity as the measure of success for a patient in the first day post-op and even during future follow-ups. One of the reasons is the fact that though refractive surgery is highly accurate right now, 95% of patients are within plus minus 0.5 of the intended target. That means you still will have 5% of patients who are outside this plus minus 0.5 zone. And for these patients, one eye is always going to be worse than the other. And that's the reason the emphasis on binocular vision is so much. If you look at published literature, though, in refractive surgery, and this is just an example of one recent article that has been published by Jod Mehta and company from SNEC in Singapore. So the commonest parameters that are looked at as outcome measures for refractive surgery are predictability. How accurate has the refractive surgery that you've aimed to perform been? Secondly is accuracy, whether what you have tried to achieve is what you have got after surgery. And this is a metric of visual acuity. And thirdly is safety, to ensure that patients do not lose vision after surgery. So these are the 3 main metrics that are across the board that are seen in most published literature. So what happened to the binocular vision that we were talking about in the clinic? When you do a PubMed search, and this is what I did a couple of days ago, If you look for vision and LASIK, you have close to 7,000 references that show up on PubMed. But if you type the same thing as binocular vision and LASIK, there are less than 100 articles that are published about binocular vision and LASIK. And why is that so? Because the most common metric that we have as a success in refractive surgery is just visual acuity. But then all of us know that visual acuity is not the only measure of success in refractive surgery. Distance visual acuity, contrast sensitivity, and a lot of subjective complaints or symptoms that the patient might have, like glare, halos, and ghosting, are more difficult to measure, more time consuming, and so they're not reported as commonly as visual acuity is. So what we did approximately 2 years ago is we started researching about visual quality after LASIK. And as an outcome of that, we got to publish the first results of looking beyond visual acuity in refractive surgery, where we analyzed the image quality of patients after refractive surgery, and this was published in PLOS One just 2 weeks ago. So what we did in this research project was we looked at the aberrations that the patient had in the clinic by measuring their aberrations on the aberrometer, and then we reconstructed their vision, and then we estimated what their visual quality will be using a metric called VSOTF. And then we measured their actual visual acuity and saw how good our estimate was. And using a fixed pupil of 6 millimeters, we were able to vary the lighting conditions. We were able to vary a lot of parameters to see how patients' vision changes in these parameters. The most basic metrics that are usually measured, that is visual acuity, seem to be about the same as in published literature. And when we did this study, we did 2 arms of the study. The first arm was to compare the controls who did not have any refractive surgery, who were age matched with the cases, which are approximately 32 subjects who had refractive surgery, either PRK or LASIK surgery. And then we compared the visual acuity before and after refractive surgery, that is either LASIK or PRK. What we found from this study is something quite interesting. I'm not going to bore you with all of these graphs and data, but what I'd like you to focus on is one specific finding on this graph. If you look at all these metrics, you look at the purple circles are all patients who have had surgery. The violet ones are the same patients who have not had surgery or their metrics before surgery. So these are the same patients. So if you focus on one part of the graph where you see that the computational depth of focus, that means we measured the ability of the patient to focus at near in a cycloplead state. This is the depth of focus of patients pre and post surgery. Computation is something that we analyzed on the computer and estimated what their depth of focus should be. We found, as expected, that as the visual quality drops, the depth of focus also drops, and most post-operative patients, these are the post-operative patients, the pink circles as compared to the violet circles, seem to have an estimated drop in depth of focus after refractive surgery. So this is what we expected to see in the patient. This is not what we really measured, but this is what we computed. So when we compared this with what we really measured, we found that our measured depth of focus was completely different from what we expected to get in the patients. And if you look at this graph, when we looked at the higher order root mean square, these are the higher order aberrations. As the aberrations increase, the psychophysical depth of focus, that is the actual measured depth of focus in patients, actually got better after surgery. You see that a lot of patients are here. These are pre-op values. A lot of these pink circles are here, and we found that the ability to see across a range is better in patients who have had refractive surgery. Now remember, these are still again measures in only one eye. Now what do you mean by depth of focus? When you have light rays emanating from a particular point and these light rays are refracted into the eye, they don't all focus like a perfect ocular system at one point on the fovea. There is a circle of confusion which is focused on the macula, and the wider the circle or the wider the two focal points between where these rays focus, the greater is the depth of focus that this patient has. So in refractive surgery, as you increase the spherical aberrations after surgery, which is something that everybody knows about, we've found that the depth of focus actually increases. So based on the findings on this study, what we set out to do is we set out to find out what happens when we have a better depth of focus in both eyes for patients who have refractive surgery. So what we set out to do was to estimate the visual quality, the optical quality of myopic eyes and compare the quality between different types of surgery, because we know that different types of surgery have different kinds of spherical aberrations that are induced in the eye. So what we did was we chose patients who were over 18 years, suitable for any kind of refractive surgery with myopia between -2 and -10 diopters. And all these patients had normal corneal topographies and who were suitable for LASIK surgery with no active ocular disease. We excluded patients who might have had intraoperative complications, but none of the patients that we set out to include were excluded in the analysis. This was a prospective randomized controlled trial over a period of 1 year, and we had to have a sample size of at least 30 patients in each group. So patients were randomized into using block randomization tables, and we randomized a total of 106 patients who had bilateral surgery of the same variety, either LASIK or PRK or SMILE. All the surgeries were performed by one of two surgeons, and the visual parameters were all measured by one single investigator. The PRK and LASIK were done on the Technolast 217Z excimer laser, whereas the SMILE surgeries were done using the Zeiss Visumax femtosecond laser. So once we did the surgery, and even before surgery, we measured objective refraction again by one person, measured the aberrations using a Hartmann-Shack aberrometer, and then we measured their high and low contrast visual acuity, and then measured their depth of focus and measured the actual clinical parameter of depth of focus, which is stereopsis. So what we did was we measured stereopsis in the lab at a total of 3 different time points at the same visit, all by the same examiner, to ensure that we have repeatability. So this was the experimental setup for random dot stereoacuity testing, where we measured stereo. So when the subjects were operated, they were seen in the clinic both pre-op, post-op at 1 day, 1 week, 1 month, 3 months, and 6 months. So we had 6 months follow-ups for these subjects. All of the measurements were done under cycloplegia with a fixed pupil size of 6 millimeters. And like I said, these measurements were all repeated 3 times. So we had a total of 106 patients whom we included in our study, of which 40 patients had LASIK, 26 had PRK, and 40 patients had SMILE. At the end of the analysis at 6 months, we had 37 patients from the LASIK group, 36 from the SMILE group, and all 26 from the PRK group available for analysis. So when we looked at the estimates of their pre-op as well as their post-op measurements, we found that pre-operatively, the average amount of myopia that each of these patients had was about the same. Whereas post-op, the patients who had SMILE tended to be closer to 0, but remember, these patients were cycloplegic. The patients who had LASIK or who had PRK tended to have very mild low hyperopia of around +0.2 to +0.3 diopters. When we measured their aberrations, we also found that the preoperative aberrations were comparable across all the 3 groups. Post-operatively, what was interesting to see was the aberrations were a little higher than after surgery in LASIK and the PRK group, whereas in the SMILE group, though they were high, they weren't as high as they were in the LASIK or the PRK group. When we measured their visual acuity, all patients seemed to have similar kind of high contrast visual acuity and almost similar amount of low contrast visual acuity. But what was very interesting to see was when we measured their stereo axis or their stereo acuity. If you look at the numbers that are there on the left side of the screen, this is the stereo acuity of these patients, the average before they had surgery, and this is the average stereo acuity after surgery. And for the first time, we saw that though in LASIK and PRK, they had worse stereopsis after surgery, the patients who had SMILE had better stereopsis than before surgery. And this sort of showed that stereopsis actually improves after refractive surgery if you compare with the same patient preoperatively. So how do you explain this? When we looked at mapping out the higher order RMS or the higher order aberrations in the 2 eyes, we found that the patients who had SMILE had much more repeatable or closer amount of aberrations between the two eyes. That means that in the PRK or the LASIK group, if the aberrations in one eye was say around 0.6, the other eye tended to be around 0.8. So they were not similar. As you can see here, the patients who had SMILE, the green ones, had much closer higher order aberrations as compared to the LASIK and the PRK patients. So what we also found was the stereo acuity of the SMILE patients as represented by the green dots here was much better than the ones in the LASIK or the PRK groups. When we also mapped out their focus curves, we found that the focus curves of the SMILE group was much closer to what they had preoperatively as compared to the LASIK and the PRK group. So the conclusions from this study were the fact that the accuracy of refractive corrections seemed to be pretty similar whatever refractive surgery you do. The higher and the lower contrast visual acuity seemed to be pretty similar in all the three procedures, but SMILE tended to induce lesser aberrations than LASIK or PRK. There was no significant drop in image quality, but what was most interesting was the fact that stereo acuity was better following SMILE compared to LASIK or PRK. This probably is because in SMILE patients we found that they have a similar aberration pattern between both the eyes, so using both their eyes at the same time, they're able to see a greater depth of view as compared to what they were seeing pre-op. And the potential application of this is the fact that when these patients become presbyopic, or when a patient who's pre-presbyopic undergoes refractive surgery or SMILE, then they probably are not going to be needing reading glasses for a longer period of time as compared to if they were wearing glasses or contact lens, which is something that is completely different from what we think about refractive surgery as it is today. And that is the reason why we concluded that when we look at estimates of success or outcomes of refractive surgery, measuring the outcomes in both the eyes and estimating the benefit that the patient is getting from both the eyes at the same time is much more important than measuring individual visual acuities or outcomes from one eye. Thank you very much.